Welcome back, Sarah. I'm so excited to be chatting with you and to dive more into the story of women's hormones and what we're experiencing and normalizing these parts of the conversations that people need to be having.
Definitely. Thank you. I'm really excited to be back on with you, Nikki.
Yeah. So there definitely seems to be a significant increase in ADHD diagnoses, particularly among women. I had a late in life diagnosis myself. Plenty of my friends have as well. Can you share insights around what's causing this rise in diagnoses and why are we maybe just now starting to acknowledge this in women?
There's definitely a significant rise in ADHD diagnosis among women, adult women. So is this a real rise? Is this just something that's happening in the environment that we're seeing more ADHD, or are we just now starting to recognize that it is a female problem as well? There's a couple, it's probably a combination of both. So when you look at the literature, it's both is going on. One thing to consider is that girls with ADHD are often missed. I mean, they're not hyperactive typically. They just tend to daydream more, but they're more flaky, for example, but they're not disruptive in schools. Girls. So the teachers, parents, they're not bothered by the girls. And so ADHD is just overlooked. So they don't get diagnosed until later in life, and it really takes a toll on women because it impacts their self-esteem, their work, their relationships all throughout their 20s. But now we know that this increase in awareness of ADHD is increasing diagnosis in both male and female patients. So I have studied ADHD a lot. I have a son, an 8-year-old son that has ADHD. And so this has been something of a personal interest of mine. And we can get into, is this like nature versus nurture? Are we doing that? Is this something that happened in the childhood's environment that's made them ADHD? Or is this a diet, problem? Or is this nature? And I think in large part, this is nature. So this is, and I think we should get into maybe what causes it. Yeah, we can talk more about stats, but this is really something that's highly genetic. So it's carried down and it is changing neurotransmitters in the brain and making this person neurotypical. And so whether they are not ignoring the negative symptoms, the signs or negative input that's coming to them, like whether it's feedback, where a normal, I say normal because everybody's normal, right? Neurodiversity is normal, right? So we're all just different. So just recognizing that this person is maybe taking into account more sensitive negative input. This is because of different combination of neurotransmitters based on their genetics. So, but this true ADHD, I think it's really kind of important to distinguish what is true ADHD versus an adult female that's like 35, say, and she gets diagnosed with adult ADHD. Is this true ADHD? Has she had it her whole life? Or is this an overdiagnosis? Because what happens when hormones drop after the age of 30, like women will hit age 30 and like 80% of their hormones drop, all of them, progesterone, estrogen, testosterone. And then she gets forgetful. She loses focus. She has intense anxiety, depression, brain fog. These are all the hallmarks of ADHD. And so does she have ADHD or is she in perimenopause, right? Or does she need just hormone replacement therapy? And this is kind of where this is interesting. And I don't know if it matters because this person really needs to recognize the reasons why she's having brain fog, lack of focus, and anxiety so that she can address it. A woman with not just because it's really pronounced in perimenopause, like when her hormones drop, she'll need hormone replacement therapy, and often those women will just get better with hormone replacement therapy alone. A woman with ADHD who undergoes perimenopause will probably undergo menopause early, and then she also needs more than just hormone replacement therapy. So she is going to need, her symptoms are going to be more severe, which we can get into, but also she's going to need more.
Okay. So when you speak to needing more in other than just hormone replacement therapy, is that referring to different types of resources and ways of managing it?
It's interesting because when you look at what's the difference between childhood ADHD and adult ADHD, and really a child that has ADHD, it just turns into adult anxiety is what it is. So this person will just have anxiety as their baseline. It's their predominant symptom, their whole young adult life. They're constantly having to do something. If they stop, they will literally feel like they're falling out of the sky. They cannot stop doing something. This is like high functioning anxiety. These people are really smart. They're doing things. They're very functional, and it's because they also feel like they can't stop doing anything. I've heard a lot of therapists say this is because of parental influence or other things. I just think this is low dopamine
I mean, there's the whole concept of rejection sensitive dysphoria, but there's also the feeling of I need to keep doing because if I'm not doing, then I'm not being productive. Because a lot of times, if you're not actively managing something, it's seen as lazy. And there's a big difference between laziness and executive dysfunction that really needs to be um, established, I think, for people who don't necessarily understand ADHD. It's not merely hyperactivity, it's not purely anxiety. There's actually something where you're like, "I need to do this thing, I want to do this thing, I can't do this thing." And that is, I think, the worst part of it, honestly, because it you internalize a lot of shame around that, and then it builds the anxiety.
You nailed it. And so from a biological perspective, which is what I think we need to understand so that we can help people. So when you have low dopamine and low norepinephrine, this is where you get this disconnect between like executive function skill that you're talking about, that want and desire to do something, and then executing on that. And so norepinephrine and dopamine have to work together in the brain in order for that to happen. And when you have somebody with very low dopamine, like when they wake up in the morning, for example, they will feel a sense of impending doom. Like it is like this very common. You talk to people with true high functioning anxiety, they'll wake up with like anxiety and what do I need to do? I need to do this or that. And so I think that really to get to like, how do we really treat this and from a like maybe a natural standpoint, instead of, let's not talk about like stimulants, and let's talk about how do we raise dopamine, for example. So we know ADHD is caused by low dopamine, and what causes low dopamine. So this is like, because it's like what causes ADHD. There's a huge genetic role. So I mentioned this is something that's passed on from generation to generation. And we know that there are these things called single nucleotide polymorphisms, right? And they're just basically SNPs. So what happens is there's a little piece in the genetic code that has a polymorphism in it. It's not necessarily changed, and those are inherited heavily. One of the most common genes that is known to cause ADHD or develop these polymorphisms is called COMT, all capital letters, COMT. And so this is a huge, functioning gene in the body, and it is responsible for metabolizing neurotransmitters, including dopamine, norepinephrine, and estrogen. So it is involved in all of those. So that's why you see women who even have just one variant. If they have one copy, they don't even need two. If they have one copy of a COMT SNP, they're more likely to have ADHD, PMDD, mental health disorders, bipolar, anxiety, substance abuse disorders, right? So alcohol addiction, any kind of drug addiction. And they also are seen to have early menopause. And this is because the COMT gene is responsible for metabolizing all of these things. And so when you're metabolizing estrogen really quickly, this person is making plenty of dopamine, but they're just like blowing through it. They're metabolizing it really quickly. And they're also making plenty of estrogen, but it's like going away super fast. And so it's really interesting that you'll see an ADHD woman when she hits her 30s, her drop in estrogen and progesterone may be more pronounced in her because she's already metabolizing estrogen quickly.
Is it something that we should be doing as women, maybe of a particular age? Maybe it's when you're 30, or maybe it's even a little bit before you're 30. Wouldn't we benefit from having sort of, as part of our regular checkups, some test of those levels so we can understand the impact?
Absolutely. So I would think this should be more mainstream, and I think there's more awareness around these genetic SNPs. So this is more of a functional medicine approach, but even functional medicine doctors are not aware. But this is how the difference in, like, you see neurotypical. It's about dopamine, and a lot of our pharmaceuticals, for example, are largely focused on serotonin. All the antidepressants that we have, they're focused on raising serotonin, which does not impact anxiety. It does not impact ADHD in women. We have stimulants that are on the market, and they raise dopamine because they're like a derivative of a methamphetamine that will raise dopamine, and that's why they work. Because people with ADHD, when you have low dopamine and you raise it, they feel calm, because dopamine actually makes people feel calm and it lets them sleep. It doesn't stimulate them. It's like a happy neurotransmitter.
It was first diagnosed. I think one of the things that's really helpful for people to understand is that if you are diagnosed late in life, and it is a very clear, you've sort of experienced this your whole life, it's validating. And I think it can help you start to navigate life with a little less resistance because you have a state of acceptance where you understand yourself a little bit more and you can start to troubleshoot or problem solve to figure out the best ways to live your life. And the other piece of it is that when it comes to medication, I was resistant for a while. And when I did decide that I was going to start taking it at the time, and the hard thing with medication, I totally get, is there is a lot of trial and error. We're not all made the same. So it sucks when you have to try something and it doesn't work or it makes you feel worse. I was overstimulated with sort of my first round of doses. It just wasn't the right fit. But when I got the right medication at the right dose, I feel like my entire world changed because I didn't understand that I think I believed that everybody else was also living their lives with 1,000 thoughts running through their head all the time, every day, with just constant curiosities and needing more information, and it just sort of felt like, "Oh, I can think about those things, but I don't have to feel manic about it," you know? And so it made me feel like I could actually strengthen my intelligence because I could harness it more. Whereas before it just felt like sort of, I it was very haphazard in what my brain decided it was gonna focus on at any given moment.
This is really important. I do agree with you. Like if we were to know earlier on, let's talk about some just natural interventions that you can do too. But like it's also about self acceptance and understanding that you do need to maybe approach problems differently. But like you said, there are natural approaches so that you can organize those thoughts or not place so much self blame, or that it will help in your relationships because ADHD people sometimes struggle in relationships with other people or in their work. So ADHD people are very smart people. So there is I have met psychologists who have done their PhD on this really overlap between giftedness and ADHD. And sometimes it's difficult to distinguish the difference between that. And so I think that's also important to remember that this, as we talked about, nobody's normal. Like this atypical versus a neurotypical person, there is this level of giftedness potentially that's there. And so you don't want to necessarily blunt any of that. So like in a young child as well, like you don't want to, you said it, ADHD, like you have the ability to hyper focus as well. And it's not because you're stressed or now because you procrastinated and now you have to get something done. It's actually like a gift that ADHD people have, and they have the ability to hyper focus when it's necessary, and that's nothing like anybody else. And so it's also probably overlapping with their potential giftedness that a lot of ADHD people do have as well. So how do you intervene when you like, how do I get, like if I have it myself, or I'm helping a woman or like my son, how do I allow them to feel that sense of calmness that you described, the ability to organize their thoughts and not be able to filter a little bit, and then also but not blunt this potential hyper focus and giftedness that could be likely there for this person. And so that is also why yes, stimulants do work, but let's talk about these natural therapies. And 80, like if you have a COMT variant, which there's no studies to show what the prevalence is in the population, but it's definitely over 30%. So this is a lot of women actually have a COMT variant. They need a lot of exercise. So exercise raises dopamine. So when the body moves, the brain produces dopamine. And so that's why you see a little small boy, like a 6-year-old who's like hyperactive and can't, like my son can't, you literally cannot sit still to like eat a meal. And you're just like, okay, like but if parents knew, they'd have a lot more patience with that, just knowing that that is the brain making dopamine and stimulating the production of dopamine. So if you make sure that kid or that person has a ton of exercise every day, it really helps them and they sleep a lot better as well. So this is actually a need. This is a need. And then sunshine will raise dopamine. So that's been shown. Things like hugs will actually raise, it's very real. So children need to be hugged a lot, people need to be hugged, and this will raise dopamine. And we also know that like sex raises dopamine as well. So it's important to also have that healthy sex life. And then there's a few dietary changes that people can do with if they have these SNPs or variants and they know that they're susceptible to low dopamine, and one of them is a high protein diet. So protein is the most, I mean, I think it's getting its recognition it deserves now. Like everybody's talking about protein. But the reason why it's so important from an ADHD standpoint is that we need protein to make neurotransmitters. We can't make dopamine from fat or carbs. Like we make dopamine from protein. Let's just use COMT as an example because I've been using it this whole time. it runs really fast. So let's say you have this like machinery that's like metabolizing dopamine as you're making it, literally. Then to slow that down, protein will actually do it, because COMT also metabolizes protein. So to make the dopamine, so you will, or it just metabolizes the protein. So you can slow that process down, just overwhelm it with protein. And then you're also making more protein with the dopamine. There's different theories as to what the amount of protein is, but I tell women, look, it's easy, just kind of target over 100 grams of protein a day, which is a lot. And maybe that could be too much for some people, but nobody's getting nearly 80, even 80 grams of protein a day. So if you just, but there's some advocates, really smart physicians online that are, advocating for every pound you weigh, it's not quite 1 gram of protein. If you weigh 100 pounds, you might need like 80 grams of protein-ish, or like you'd aim for like 80 to 100 grams, So even if you were to try to aim for your own weight, like if you weigh 110 pounds, aim for 110 grams of protein, you probably won't make it, but you're close enough. You don't have to make it a full-time job. But definitely women that have ADHD do way better on high protein diets. They feel like they can focus better. Their mood is lifted. They definitely sleep better. So all the things that are in, so collagen's a good form for women too, because it has a lot of glycine, and it's like a straight, it's easy for them to digest and make dopamine from it. Another supplement that they can take that converts to dopamine is L-tyrosine. And L-tyrosine is just an amino acid. And if you have B6 with it, which is an important B vitamin, like its active form, and you take L-tyrosine, women will also find that their mood lifts. So if they're struggling with it, their anxiety lessens, their depression lessens, they're able to have a little bit more mental stability, because ADHD can be a little bit of mental instability as well. So you can see, depends on how people, sometimes they do get depressed, sometimes it's anxious, they don't really, and it can all happen within an hour. And when they, so, and this will help stabilize their mood a lot more for them. This is a natural way to raise dopamine. And I do want to mention though, people will try to raise serotonin at the same time, with say, rhodiola rosacea. I see that all the time. Rhodiola is a very popular for ADHD to raise dopamine, but it also raises serotonin. And just people have to be aware of themselves, ADHD women, because sometimes they don't need to raise their serotonin. It's just dopamine, and they can actually make their mental, they're a little bit more unstable.
What is the disadvantage of having too much serotonin? I'm not familiar with that. I feel like most people have a deficit, so you hear about that, and then I don't know that I understand what a surplus of that would do in terms of how that affects you.
Sometimes we can't metabolize serotonin as quickly as we need to. So if this person is atypical and they can't even, they're metabolizing dopamine too quickly, doesn't mean they're metabolizing serotonin too quickly. And so if you overload them with serotonin, and too much serotonin can cause, at the very best, some bluntedness, right? They're going to feel blunted. They're going to feel sleepy. They're going to feel moody. They might start crying out of no reason, right? Because they're now just a little bit weepy. At worst, it can cause sweating and diarrhea and a lot of systemic problems. And sweating and diarrhea are kind of the first signs that you have too much serotonin. People on medications that are raising serotonin will know this, that they have to watch out for some of these things. But for a regular person just trying to take supplements or something, it's usually, I find that dopamine is the problem, not serotonin. So to really not necessarily try to raise them both at the same time, if you're, is just an observation. And I think that this needs more, we definitely need to be looking into this more.
In a place where your serotonin levels are too high, is there something that you naturally can do to lower that?
Just avoiding what's raising them in the first place. Because usually when they get too high, it's because somebody's doing something. You're taking something like a supplement. There's a lot of herbs on the market, and so when women get to, perimenopause and menopause, they try things like black cohosh and other herbs. Those don't actually treat menopause. They don't act like estrogen. They don't replace estrogen, but they do raise serotonin. And so this can cause these kind of symptoms. And so I just tell, herbs are not benign. They do things, they don't necessarily do what you want them to do, but they're doing something. And typically it can be something like that. I also think it's important to kind of mention why this approach for people, if they learn early that they have ADHD or that they have one of these variants and that they're metabolizing things really quickly, they need to know, because they need to be on hormone replacement therapy earlier. They also need to know because they may need more hormone replacement therapy than a neurotypical person, a woman. Because, like, for example, if she's metabolizing really quickly, the same dose for her is not going to get her levels up as high as it would for somebody else, right? So, to cover her symptoms and make sure she's feeling well and not having symptoms, she may need more. So, this information is really valuable for people. It's also, important because if they implement some of these lifestyle changes that we're talking about, which are these like sex, exercise, diet, sun, and I understand that some people need stimulants, but the problem with the reflex, like the women will go for menopausal symptoms, perimenopause. They're, say, a 35-year-old, I keep getting, because it's like in their mid 30s is when it kind of starts, like 30s. And she'll go to, because she can't function, she can't focus, she's having brain fog, and she's automatically put like on a stimulant. You have ADHD and given a stimulant. And over time, if somebody just takes stimulants and they don't address like the underlying cause, like if they're not, the one thing to consider about these stimulants is that it forces the brain to make dopamine, but when the brain makes dopamine in a forced artificial way, it also makes a toxic dopamine at the same time. So there is a potential, right? There's not a lot of research or long-term studies, but there's a potential that these stimulants will increase somebody's risk for Parkinson's, right? So because we know that there's the link between low dopamine and Parkinson's and other types of dementia. So dopamine is needed for motor function as well. And so if this person knows, this ADHD, that what her risk is, and there's this growing body of literature that shows the link between ADHD and Parkinson's, right? And so these people are more likely to develop Parkinson's in older age than a person that doesn't have ADHD. So they need to make sure that their hormones are always optimized, because we know that estrogen is highly protective against dementia and other neurodegenerative diseases. So you want to protect your brain, you want to make sure that your hormones are at optimal levels at all time, and then you want to make sure your dopamine levels are high. And and taking the stimulant, like that are on the pharmaceutical stimulants, it also raises cortisol over time. And this can cause problems with the immune system and with the gut functioning well, and some other concerns that she just may want to consider for long term, right? Like, is this something that I want to do long term, or I need to really address these root causes? And the root cause of this ADHD, or the things that she's feeling, is low dopamine, low estrogen, and these can be taken care of naturally. She's never going to be, ADHD people are okay. Like, they're never going to be, and it's a daily thing too. Like, you're going to have to take L-tyrosine daily. You're going to have to exercise daily. You're going to have to eat protein daily. You're going to have to take your estrogen. Like, you're going to always have to be on top of this to feel well. But the good news is that if you find out that this is what you are, and you can feel amazing, right? Like, you can reduce your anxiety and feel better, like, forever. And just, it's knowledge is power. And if you know about your health, and the more you know about it and the more you're empowered to do it, you're in control of it, and you get to control what your future looks like.
Yeah, I love that, and it's so true. I think it's really liberating when you can understand your circumstance well enough to be able to address it in a way that is more holistic perhaps, but especially even just the information that you're sharing around some of these links. And, as you said, obviously there's more research and whatnot to be done. But I do think that these are important conversations to have, because we do live in a society where there is very much an emphasis on pharmaceuticals and trying to treat these things. Um, and I think also because we're in a place where people are Googling things and they're trying whatever somebody else is doing, and maybe it works for this person, but it it is a lot of trial and error. It's patience with yourself. It's understanding that the results might not be as immediate as you want them to be, but it's sort of like anything in life where if you see somebody else doing it, it's possible. So, what measures are you willing to take to have those results in your life, and making sure that you're tailoring that, as you mentioned, to your unique needs based on what your life is, because it's yes, your brain, your body, and also the circumstances around you, because not everybody, has the same type of life or the same support in their life to be able to do all these things. So it's all very I think unique when it comes down to the day-to-day implementation for people. But I think at large what you're saying is these are really good options for people who are trying to kind of, turn the dials and figure out what's working for them. let's start with what is endometriosis, because I'm willing to bet a lot of people think they know, myself potentially included, and that knowledge is probably limited.
Yeah, definitely. I think that everybody has this, misconception about it. And we can start by saying what endometriosis isn't. So, endometriosis is not just painful periods, right? It's actually where endometrial like tissue, so it's not even, it could be even endometrial tissue, but it can also be endometrial like tissue that grows outside of the uterus. And this tissue isn't supposed to be there. So it causes a local inflammatory response of that uterus. So the uterus itself becomes inflamed. And inflammation we know can cause pain, right? So, but it is inflammation of the uterus. But since the tissue is not supposed to be there, it also triggers the immune system. So it triggers a whole body or a systemic inflammatory response. So you have a chaotic immune system, you have chronic inflammation, and then we even see autoantibodies present. So the immune system will try to attack the tissue. And so, even though it hasn't been classified as one, it has all of the necessary ingredients to be called an autoimmunity or an autoimmune disorder, which there is some people and researchers speculating that endometriosis is actually an autoimmune disorder. It's estimated that there are like 200 million women worldwide and 7 million women in the US that have it. But this is likely largely underdiagnosed because women are often, as we know, we've discussed that they're dismissed for that this is just part of being a woman, you have a painful period. And it's hard to know because people have different tolerances of pain. And we have, and this is a huge problem. Like women will go years, 7 years before they're diagnosed with it. So, and they're telling people that they have painful periods, and so there's no other way to diagnose this other than surgery. Surgery is the gold standard, which means you have to like get in there to see if you have it. That's not good because doctors aren't really going to just go in there and, unless they need to.
Well, and I think as a patient, you're probably not inclined to be like, can maybe we should do surgery to see if that's what it is. That feels really counterintuitive as a patient. Because what if it's not?
Surgery has risks. We shouldn't be going into surgery. It can increase infection. People die during surgery. I mean, we shouldn't just do surgery. So it's really like be conservative approach, and also we know that there's antibodies present, for example, but there are no labs that have clinically validated a clinical test for these antibodies. So there's no real blood test for endometriosis, even though we're probably capable. Like, again, we have self-driving cars out there. We are capable of having a lab test. We just don't have one yet. And so this is why it's a big problem and why it goes so long without being diagnosed. Since we haven't studied it as much as we should, because we know that we don't study women as much as we should, the treatment is actually surgery as well. So they'll wait, and then they do laparoscopic surgery to remove this tissue or lesions, and then and it's just a Band-Aid fix, right? If you don't treat the root cause, you're just going to go back in for surgery another time. And I think we should talk about what is this root cause. In order to talk about the cause, let's talk about what conventional medicine thinks is the root cause. And obviously they're wrong because it's not working. Like there's still 7-10 million women in the US suffering from it. Everybody's talking about it. It's all around us. So if their solution works so well, it wouldn't be a problem, right? So their solution is that they think estrogen causes endometriosis. So they want to reduce the amount of estrogen to like 0, and then the endometriosis will stop growing. And so this is the conventional treatment. And it's just bonkers to me because this is also a Band-Aid fix. But the way they take away women's hormones or estrogen is that they actually put them into a menopausal state. We have gonadotropins and drugs that do this, that actually will make estrogen go to 0. We can also give her birth control. So we know that birth control is not hormones. What it does is it stops the production of your own hormones. So it makes all 3, estrogen, progesterone, and testosterone, go to 0. And so the standard of care is like birth control. Here, take some birth control and stop your periods, because then if you don't have a period, then you won't have any pain. They're not going to treat the root cause that way. They're just going to stop your symptom of having a period. But how is that making a woman healthier, right? Like, how is that making her endometriosis go away? It's not treating the autoimmunity. Very rarely does the immune system just attack one thing when the immune system's triggered and you have an autoimmunity. It's not just making antibodies to the uterus. It's making antibodies to other things, glands particularly. So you need to really address the underlying immune dysfunction, right? And so none of that's happening with birth control. In fact, birth control makes it worse typically because you're taking away all these hormones.
I'm curious, do you know why the assumption was estrogen is the cause of endometriosis?
This is because, well, as we know, estrogen's always been labeled as a bad guy, right? Until now, we think it's caused a lot of problems. And the early studies that looked at these women, they drew hormone levels for these women with endometriosis, and they found estrogen to be around 400. Okay, so let's say 400, and then they said these levels are all elevated, or they have estrogen dominance.
Is there a baseline for estrogen that like would 400 would be high?
So a woman in her 20s that's ovulating, her estrogen gets up to like 1,800 picograms per milliliter. So 400 is not high, and when women get pregnant, it gets up to 40,000. Right, so 400 is by no means high. The problem here is that they know, progesterone is practically zero in these cases, and so the idea that we know that, or that they think that estrogen causes endometriosis, is because estrogen stimulates the uterine lining. It stimulates the growth of endometrial tissue, and so they just automatically made the connection. Oh, okay, so estrogen must be causing this, but in reality, what they're missing is that progesterone is what regulates the growth of endometrial tissue. Progesterone stops the growth of the lining. And so that's what's causing the proliferation, is the absence of progesterone. It's not the presence of estrogen. Estrogen is normally supposed to be there, and 400 is not high. So actually, and so everybody says estrogen dominance, and then they automatically think that estrogen's a bad thing, because even that phrase makes you think that estrogen's a bad thing. But there's a lot more interest, and it's more accurate to say that it's an estrogen to progesterone ratio, because progesterone is a woman's main hormone. And when it's really, really, really low, like zero, the only hormone that's around is estrogen. And so it's like, that's what they call it, estrogen dominance. It's not a problem with the estrogen. It's a problem because there's no progesterone, if that makes sense.
So there's a progesterone deficit that is sort of has made the medical community assume that estrogen is the culprit.
You got it.
But that's because you can't see the progesterone, so you're not looking to it as a source of the problem.
Progesterone is a woman's main hormone. It is 16 times higher than estrogen. It is 60 times higher than testosterone, and everybody ignores it because we dismiss women and their health all the time. So this is not very surprising that we have not caught onto this. But progesterone is what's protective from endometriosis. And we know that when progesterone levels drop, women get at risk for all types of autoimmunity, not just endometriosis. So let's say it is an autoimmune disorder. This would actually not be surprising either, because we see celiacs, we see Hashimoto's, we see lupus, multiple sclerosis. Autoimmunity is like 4 times at least more common in women than it is in men. And it's because progesterone is very, very important to modulate a female immune system. So progesterone binds directly to B cells and T cells in the immune system, and it organizes it. It makes sure that everything's in the right ratio, and it will organize it. And this is also, and it kind of modulates it. And this is how women are able to have babies. They have a foreign body literally in their body, and they don't attack it. Their immune system doesn't attack it. And it's because progesterone is able to modulate and organize and control this immune system so well. And so when it's gone, like she is susceptible to autoimmunity and diseases that are like this. And so we know this is not like this is something we know. So when women get pregnant, their progesterone levels get really high, we see autoimmunity completely disappear. Lupus goes away, so does celiac disease in women. So we know progesterone, how critical it is for this.
What do you feel is preventing us from really diving deeper into that when there's correlation to the benefits of making sure those levels are where they need to be? Is there a reason medically? Are we just not moving fast enough towards what we see as a potential solution?
I think that part of the confusion is because women have birth control in the mix. And so doctors are not trained. They have literally no training on hormones. Like I think that's getting out in the public awareness. So we can't really blame them, but they're being fed this pharmaceutical birth control. And so doctors think that they're giving women hormones when they give them birth control, but it's not. And so it has like a fake progesterone in it, and it binds supposedly to the progesterone receptor. But the thing is, it's not progesterone. So when you have something that mimics or binds to that receptor, it doesn't mean that it gives it the same signal to the cell, right? So it can have a really strong signal or a weak signal or a different signal or not a signal at all. It doesn't act, it's not progesterone. So doctors think that they're they just don't they're just not educated. So this has to be put into doctors who do well, like longevity and wellness and functional medicine, and people like practice medicine like me in clinics, then this is probably where it's going to change first. And so women need to be aware of it. They need to be like taking control of their own and advocating for themselves. They don't need to accept that birth control or surgery is an answer for them. And it's also a lot of confusion because endometriosis, like the average age of onset, I think this is, so if it happened to menopausal women, I think that they'd be like, oh, it's hormones. You know what I mean? I think it'd be a little bit more obvious. But what's happening is that it's happening to women from age 25 to 35, which is a really young cohort, like a really young group of women. And so why is this happening to young, like they should have plenty of progesterone, but that's not the case. We're just seeing that, and it can even happen in puberty, but women need to ovulate in order to make progesterone. So if they're not ovulating or there's environmental, like, so let's talk about this. Like, why is there a young population of people, a ton, that have really, really low levels of progesterone? So it could be birth control is doing it. They're taking birth control. It could be that there's environmental factors. We know things like chemicals in the environment, BPA, phthalates, fragrances, all over lotions and dyes and food and everything that we're eating and consuming and that's around us are like endocrine disruptors that are stopping the production of our own hormones, right? Again, they're not estrogen. They're just stopping our own production of progesterone. And so when they stop progesterone and from making it, and so it could be environmental that a 25-year-old is not making progesterone, but it is something, and it could also just be ovarian failure. We were not meant to really have babies that, into our 30s and 40s. So this could be genetic. She could be have a genetic variant that's making her metabolize estrogen really quickly, which we've talked about in other episodes. So that's possible that she's just really low on hormones because of this genetic variant.
So, are there specific symptoms that you would say are important for women to pay attention to that might indicate that they are dealing with endometriosis or in some capacity a progesterone deficiency?
I think the one thing to tell women is that it's pain that's beyond a normal menstrual cramp. We all know what that feels like, and this is beyond that. And women, we should listen to them and believe them. But it's, it's easy. Think progesterone stops the proliferation of the uterus, of the lining of the uterus, and it also stops heavy bleeding. So if you don't have enough progesterone, you're going to have very heavy menstrual bleeding. And there's women that will, with endometriosis, that they say they have really heavy periods, really heavy painful periods. This is not normal. We should have light, short periods that should not be painful. Really, our ancestors probably had that. So really, the women that have painful, heavy periods should think low progesterone. If they have, and then other things that are hallmarks of endometriosis that are not normal, like just not a regular period, is that there's pain outside of the period, right? So like you're not even on your period and you have pain. So you pretty much have chronic pelvic pain. And then you can also have pain before or during or after sex, like kind of this during after sex, where the pain is like deep inside the pelvis, right? So it doesn't feel like superficial intercourse pain. This is something that feels like it's within the uterus ovarian area. And then also women with endometriosis can have painful bowel movements. They have pain in the bathroom. So this is important also because bearing down and using the restroom shouldn't cause pain this way in the pelvic region. And this pain is from these little tiny lesions. So you can even have little tiny pieces of tissue or lesions on the uterus. They don't even have to be that big for her to have a lot of pain. And that's because the lesion can involve a nerve. It can trap a nerve. Blood can get trapped in these lesions, right? And that can make the inflammation worse because the body's trying to get, like, because you have blood that's like just sitting in there. You can have scar tissue. Scar tissue can damage nerves, right? So you damage a nerve with scar tissue, then that's where you get the chronic pain, is when you're damaging nerves. The lesions outside of the uterus can also form what's called adhesions. And this is basically like a full band of scar tissue. And the scar tissue can stick to another organ, and it makes the organs stick together, which is horrifying when you think about it, that your uterus is sticking to your bowel, which is sticking to your ovary, which is sticking to like your rectum. I mean, it's like everything's stuck together. And so that's why when you have sex or you have a bowel movement or you're urinating because the bladder's there, right? So everything's like stuck together, you have pain. And then the lesions and the scars have involved nerves, right? So this is why you have this painful, very painful situation. And so when you have pain for 7 years, like when these women go 7 to 10 years without help, you have chronic pain. You have a person with chronic pain, and there is what's called a central sensitization of the nervous system. So the brain literally becomes more sensitive to pain. So this poor person actually becomes, even when they're not inflamed, or these situations where they're not on their period or there's not inflammation, they'll still be in pain. And this is just a thing that we see with people with chronic pain.
So, question about the pain that's happening when you're not experiencing your period. Is that you're obviously mentioning sort of the bowel movements and things like that. Is the other pain, is that around the time of ovulation and things like that where you might feel pain? Is it normal to have cramping during ovulation? I'm asking. This is actually a personal question as well as something I'd like for other people to understand.
Kind of, we don't know if women are even ovulating when they have endometriosis too. Like, you don't know. We just think that we ovulate and then we feel like it's, we're cyclical like women. And so I hear women say, well, I'm ovulating, but you don't actually know if you ovulated, right? But you're just talking about like mid-cycle pain. And even if you did ovulate, like, it's not necessarily the ovulations causing the pain, but this mid-cycle pain could be endometriosis, and it's just the inflammation in that area that's acting up at that time. And it's this scenario. And this is common. It's not that these women, and it could be, endometriosis can be a spectrum as well, right? Like, it doesn't have to be like so black and white. So it could be that there is like I said, you don't have to have a very big lesion. You can have a tiny, tiny lesion and not have it all over. You don't have to have endometriosis all over your pelvis to be in pain.
I mean, that's fascinating because I certainly had no idea about that, and I think that's really insightful considering the fact that you're like, the only way they can really diagnose it right now is if they do surgery, but if it's something small, is it something that you even think about as endometriosis potentially? I feel like I just need there to be a lab test. This is silly that we don't have it.
Yeah, well, we know what we do. Well, it's a good point you pointed out. I mean, I think that this is true. We need to get to the point where we have a diagnostic test. But we do know when progesterone's low, we can measure progesterone. We know when your body's struggling to make it because we can measure FSH and LH, and we can measure estrogen and testosterone. So we can measure hormones. And we know that if, you're having painful periods, and even if it's not endometriosis, like, we can still stop that with progesterone therapy. So yeah, so I mean, it's like, even if you're a woman that's like, I don't know if I have you're questioning, do I have endometriosis? Should I, or is this just a painful period? We dismiss this all the time. This is why it's underdiagnosed, because women also dismiss their own symptoms because, like, this is just a part of my cycle, and we actually just think that's normal, and so we also dismiss it. But if you're having pain and on cramping, it needs to be addressed as either a deficiency of some kind. There are lots of that help with cramping besides hormones, and we can get into them, but progesterone is really, really important, for that.
Are there things that just from your experience and perspective are beneficial to help with cramping during periods for women?
So I think we already throwing out the conventional way, right? That's not going to work. Like, you're just lowering all your hormones to zero. But and there's no doubt in my mind that you treat it with progesterone, and that helps the vast majority of it. You're going to prevent the proliferation of the endometrial tissue, both inside and outside the uterus, with progesterone. You're also going to reduce inflammation. Like, progesterone reduces prostaglandins, cytokines in the immune system. This is what inflammation is. Inflammation is simply a disorganization of the immune system. So we need to organize that. And the only way to do that in a woman is with progesterone. And so you want to keep all those immune cells working properly and that inflammation really low. So other ways that you can, so let's say we get 80% of the way there with progesterone therapy, or even 90%. And in most of these women, I should note, don't just need progesterone, they need estrogen too. Very rarely is a woman just making estrogen. Like, she's just not making any hormones. Like, she needs all 3 hormones to be replaced with endometriosis. So after you do that, then I think the question is, what else can you do to help manage some of those symptoms if they are still coming about, or let's say she's still healing over time, because this can take time to reverse. Like, any autoimmune disorder can take time. So other things that can help with cramping is magnesium. So the uterus is just a giant muscle. It's like giant smooth muscle, right? It's helped push the baby out. So magnesium relaxes muscles. And so the best way to get magnesium into the body is through the skin. So I tell women Epsom salt baths are really great to help with uterine cramping. Another thing that's interesting that's getting some research that needs to have more research, this is kind of like a newer, more progressive advancement, is that iodine could be potentially something that would help because there are iodine receptors within the endometrial lining itself, and they help regulate the growth of the tissue. Iodine, we know, helps with fibrocystic breast disease, and it helps with other conditions as well in the reproductive sense for women. And so iodine therapy is important for every woman. It's like one of my favorite supplements. Like every woman should be on it kind of thing because it helps us metabolize hormones. It helps with the signaling pathways of metabolizing estrogen. And it also helps regulate the growth of tissue in like the uterus, for example. And so iodine, magnesium, and then of course things like methylated B vitamins are needed to help some of these genes that we use to metabolize hormones. We just need methylated B vitamins for them to work properly. And so it's not going to get you there. Like if you had endometriosis and you just took iodine, magnesium, and methylated B vitamins, if you just did this alone, it's not going to work. Because again, you have an autoimmunity that you're not addressing. So you can just work out, like you can take some supplements, but no way is a vitamin going to stop endometriosis. But for you, like if you started hormone replacement therapy to eliminate these mid-cycle cramping that you have, and then on top of that, you added in proper supplements, you would get rid of this. How do you replace progesterone enough for a young woman aged 25 to 35, for example, or something to help her? I am in favor of bioidentical progesterone. It's exactly like what our body makes. So none of this fake progesterone that's found in birth control. It's not the same thing. It's not going to do the same thing. So, again, and you also need to replace all three hormones to treat a woman. Like if you just give her progesterone, she's also not going to get better because her other hormones are low too. As I mentioned, the estrogen of 400 is not high. That's low. So especially for a 25-year-old. I'm a huge fan of bioidentical progesterone. So it's exactly like what our body makes. It's identical to the progesterone that you are no longer making. And so bioidentical progesterone is not FDA approved for treatment of endometriosis, right? Because it just has not been studied. So we can prescribe it though as off-label, and there is enough evidence to support its use for endometriosis that it would work. And it does work. I've seen it. I see it all day long, right? So I've done this in clinic for many years and I've seen it help endometriosis patients. And I want to emphasize that it's not just progesterone that we need to replace. It's all three hormones. You have to replace progesterone, estrogen, and testosterone in women in order to treat her autoimmunity and to treat the condition like in a holistic approach. And this is exactly what Inner Balance is doing. And I should mention that oral progesterone is not enough progesterone to do this. Only 20% of oral progesterone is absorbed. That's how much bioavailability it has, which is really, really low. And it's not enough for a 25 or a 35 or even a 40-year-old woman. So this is not what we advocate at Inner Balance. We have our own formulation that works really well for endometriosis.
You were mentioning some of these things aren't FDA approved, but they've been proven effective, and you're allowed to provide them to people. Are there any things? Are you aware of any? I guess would it be legislation in place? But like, is there progress towards getting FDA approval on this?
So the reason why bioidentical hormones are not FDA approved, they're only approved for low ovarian function. Which, if you're only have an estrogen of 400 and you're not making any progesterone, you have low ovarian function. Right? So it is FDA approved for that. The difference is that it's not approved specifically for endometriosis, so insurance is not going to cover it. If you want your insurance to cover your bioidentical hormones for endometriosis or PCOS or anything else, it's not FDA approved, so the insurance is going to say no. And the reason why they're not FDA approved is because you can't patent bioidentical hormones. They're naturally occurring. So no pharmaceutical company, no big company with a lot of funding has the money to run a clinical trial to get FDA approval, which the FDA requires large clinical trials. So it's just a big government holdup, and you don't need FDA approval. Like, so if a woman knows that she's not making enough progesterone, you're just simply supplementing what she can no longer make. And she should feel comfortable and safe about doing this. We don't need, she just shouldn't feel like there needs to be a big trial necessarily, and she needs to understand why it matters. And it's usually for insurance coverage. So another like therapy, for example, that we use for autoimmunity, very commonly, we've shown that it works. There's a lot of research behind it actually, is low dose naltrexone. And what it is it's a tiny, tiny dose of naltrexone, which is a pharmaceutical drug. And when we use just a tiny dose of it, we find that it has the opposite effect of its huge dose. So just to get into it a little bit, naltrexone we use for alcoholics to prevent them from drinking more alcohol. And we use like 50 milligrams, a huge dose. But if I were to give somebody with autoimmunity just a small amount, between 1 and 4.5 milligrams, it actually stimulates and organizes the immune system. And what it does is it lowers inflammation and it raises endorphins. And there are tons of studies on low-dose naltrexone and autoimmunity, such as rheumatoid arthritis, Hashimoto's, lupus, multiple sclerosis. And there are some researchers that are proposing that low-dose naltrexone be treated for endometriosis as well. Again, I don't think that you can just take low-dose naltrexone and heal your endometriosis. I think you're not making any progesterone and estrogen, so you need hormone replacement therapy as well. But it's an example of a drug that low-dose naltrexone is not FDA approved, but it has substantial research and literature. You have to pay out of cash, out of pocket for it. Insurance isn't going to cover it. So we have a lot of alternative kind of therapies that really work for autoimmunity and really work for these kind of things. It's just that somebody's going to have to pay out of pocket for these, but they're not expensive.
You're at the cutting edge, I think, of something that is extremely transformative for the medical field. And so I'm just curious how you landed here.
It was a long process. So I'm a pathologist by training, but that means that I'm highly trained in the pathophysiology of the body. So I understand the diagnosis, the basis, the formation, and the treatment of disease, all diseases in the body. And so when you look at it holistically, what I was trying to solve was probably my own problems, my family's problems. When your family gets sick or you get sick, you really try to figure it out fast. And I think that that's what happened in my life in my 30s, is that I realized that conventional medicine did not have the answers that I needed in order to feel amazing my entire life, which I wanted to, right? I deserve it. I wanted to feel the best that I could feel. And conventional medicine didn't have any answers for me. And I knew everything in medicine. So that they had taught me. So when you try to solve a problem like autoimmunity, there's no answers in conventional medicine for that. You have to look at the body and harness the way the body naturally works and the way it naturally heals. And that's how you can solve the problem. And that's what I tried to do. And it wasn't to start inner balance initially or anything like that. I just wanted to learn and know. And so when you really learn what controls and regulates every process in the body, you learn that it's hormones. I heard somebody once say that the hormones are the CEO of the body, and this is true. And so you can actually prevent disease with hormones. And they're so powerful. Like, this is where the power lies. And this is where medicine needs to progress and we need to learn in terms of preventative care. When I learned this just about pathophysiology of disease, is how important hormones were, this is where I learned how to treat women, and women especially, because this is where women have no help right now. And they also have the bulk of the problems, the bulk of the sickness. They're the ones being diagnosed with the depression, the anxiety, the ADHD, the autoimmunity, all of the problems their entire lives. And so why is this? And we really have complex, but it is all regulated by hormones in the body. And so this is why I came down the path. And it was just, because I think it's so fascinating and it's so important, right? This is something that we can help everybody with this, but it was mostly to help my internal circle, right? Myself or my family at first.